So we've spent quite a amount of time on the pulmonary system, and now we're going to shift our focus just a little bit over to the cardiac system. And when we look at the cardiac system, it's got a main purpose to transport that oxygen and that carbon dioxide and other nutrients all around the body. And so what happens if there's poor circulation despite good ventilation and good oxygenation? Well, I can get as much oxygen in as I want, and I can try to remove as much CO2 as I'd like. But if I don't have anything to circulate that, what does that mean? Well, it's still going to lead to poor outcomes, and we'll talk about it as we jump into this a little bit more. When we look at the heart, basic anatomy, we see that we have one heart with four chambers: the right atrium, right ventricle, left atrium, left ventricles. Your atria are on the top, and your ventricles are on the bottom. When we look at this organ, it is only about the size of your fist. Now think about that. That organ is shifting the blood all over your body from the top of your head to the tips of your toes. That organ that's the size of your fist is shipping all of those nutrients around your body. It's cone shaped. It only weighs about 250 to 350 grams. So relatively light. I think about a box of paper clips. That's about all that it weighs. It doesn't weigh a whole lot. And it's housed and it's protected within the mediastinum, and it's protected behind the sternum. You've got the spinal column that protects it. The lungs kind of encompass it. The diaphragm's below it. So it's well protected behind many layers because it is such a vital organ. When we look at it, about 2/3 of it sits left of the midline. 2/3 sits left of the midline, whereas 1/3 sits right of the midline. And it sits between about the second and the fifth intercostal space. So it is up here with the angle of Louis. Angle of Louis tells us where the second intercostal space. That tells us that that is the top of the heart. Now we have to make sure that we don't get confused with nomenclature or naming conventions when it comes to the heart, because when we talk about the apex of the heart, what we're talking about is this point right here. That is the apex of the heart, and this is the area that we would find the point of maximum intensity. The point of maximum intensity. And what this does is this shows us where we're going to get the most bang for our buck, where we're going to be able to feel or even hear the heartbeat the strongest. And the way that we identify that is we can press between the fifth and the sixth intercostal space below the nipple line. So if I get into the fifth and sixth intercostal space right below the nipple line, I can feel that point of maximum intensity, which is right where the apex is. So that is a critical position when it talks about where to locate the apex. We can use the point of maximum intensity to help us find that out. Not to be confused with the apex of the lung, which would be the top of the lung. So just to make sure that we don't get the nomenclature confused, the apex of the heart is here at the point or the tip of that cone of the heart. The base would be the broad side here. The broad side here is the base. It's about 9 centimeters long, and it points to the right shoulder. So this area here is going to point to that right shoulder. When we look at the apex, that actually points down to the left hip. Now we have an interatrial and an interventricular septum. When we look at these are simply dividers. They're anatomical structures that divide the right atrium from the left atrium and the right ventricle from the left ventricle. That's what a septum is. A septum separates. Now when we look at the right side of the heart, it is its own pumping system, and the left side of the heart is its own pumping system. We get blood that comes from the superior and the inferior vena cava. So the superior vena cava and the inferior vena cava that bring blood into the right atrium, From the right atrium, it moves into the right ventricle through the tricuspid valve that then goes into the pulmonary arteries through the pulmonic valve that goes into the lungs. And then from the lungs, we get blood into a completely separate system, which is, or the left atrium to the bicuspid valve or the mitral valve into the left ventricle, out the aortic valve into the aorta, into systemic circulation. So when we look at the two different systems, we have one system that is pumping deoxygenated blood, and we have another system that's pumping oxygenated blood. When we look at the size comparison of the atria to the ventricles, the atria are a lot smaller in comparison to the ventricles. And even the left ventricle is bigger than the right ventricle, but we'll talk about those as we continue to get into this. So the next thing that we want to talk about here is the pericardium. The pericardium is actually a double-walled sac that protects the heart. So not only is this housed in the mediastinum, surrounded by all of those structures that we just talked about, it has its own protective mechanism called the pericardium, or the pericardial sac, that protects the heart itself. That outer wall, it's a fibrous pericardium, and it has a dense connective tissue. When we look at the outer wall, that outer wall is designed to protect the heart, and it anchors the heart to the diaphragm and to the great vessels. It prevents the heart from overfilling. So that pericardium is designed, that outer connective tissue, that outer wall is designed to keep the heart from filling up too much. So when we look at the inner wall, we have the visceral pericardium. We have the visceral pericardium and we have the parietal pericardium. So the inner wall is going to be our visceral pericardium, and this is a serous pericardium that is thin and slippery, and it has that serous membrane very similar to the pleural cavity to help with the movement of that structure. It helps reduce the friction that's associated with those structures moving across each other so often. Now the two layers, when you have your parietal pericardium, you also have the visceral pericardium, and between there you have the pericardial fluid. That's going to be important when we start talking about different conditions, when that fills up with blood or with fluid, or there's an overwhelming infection that sends inflammation. All different things that can start to happen when it comes to this pericardial fluid or this pericardial sac. So one of the infections, or one of the conditions that we're going to talk about, is pericarditis. So we just talked about the fact that there could be an infection here with the pericardial fluid or the pericardial sac. When we have an infection or when we have inflammation in that area, we get what's called pericarditis. Now, when we have pericarditis, one of the ways that we can identify that is by listening to the heart. And when we listen to the heart, what we're listening for is a pericardial friction rub. And that's very similar to what we would hear with a pleural friction rub. So the same thing that you would hear with the lungs, you can hear with the heart. And that would tell us that there's inflammation of the pericardial sac. Another thing that we can have is what's called a pericardial effusion. When we have too much fluid here in the pericardial sac, you get a large amount of fluid that accumulates in that pericardial sac. It will start to squeeze that heart so that it doesn't have the space to expand and contract, expand and contract. So if it cannot expand and contract, what then happens to the amount of blood that can be ejected from the heart? Or what we're going to talk about is a stroke volume. A stroke volume is the amount of blood that can come out with each beat. And if that starts to decrease, then the overall amount of cardiac output will decrease. But before it does that, if I can't get blood out, if I start to get less blood out, what will the heart rate do to try to compensate to keep the overall amount of blood circulating? That's right, it'll increase. You'll get an increase in your heart rate. When we have that, when we have a decrease in stroke volume from a pericardial effusion, and you have the response, the body's natural response to increase the heart rate to maintain cardiac output, we call that a physiologic response. So we talk about a physiologic response to all kinds of conditions, but I haven't used that terminology just yet. And I want to introduce it now. So when you have that decrease in stroke volume, the body's going to respond in a certain way to maintain cardiac output. And the way it's going to do that is going to increase the heart rate. So let me show you in terms of a mathematical equation. Cardiac output equals stroke volume times heart rate. So when I have this pericardial effusion that's squeezing that heart, not allowing it to get fluid out, I get this decrease in stroke volume. Well, in order to maintain the same amount of cardiac output, what does the heart rate need to do in order to maintain the same output? Well, it would need to increase, right? So let's put some numbers to it, right? Let's say that the stroke volume is 50 and your heart rate is 100. That gives us 5,000 mLs that come out. So let's convert this 5,000 mLs. Let's say that that's 5 liters that come out when there's 50 mLs that are pumped 100 times a minute. So what would happen? What would happen if I dropped 50 mLs, if I dropped 50 mLs down to 30 mLs? Well, if I maintained the same heartbeat, my cardiac output would be 3 liters. Well, 3 liters isn't adequate for a patient. So the body's response is to try to get that back to 5 liters. So if I know that I'm only getting 30 mLs out, what is my heart rate going to do to maintain that 5 liters? Of course, it's going to increase. So when we get that increase in heart rate, that is called a physiologic response. When we get to the point that the pericardial effusion has taken over so much that it's decreased the amount of volume, and I've tried to respond the way I'm supposed to, but I can no longer keep up. I can no longer keep up with what I need to. You will start to see that heart rate trend downwards now. You'll see that heart rate trend downwards now. And when we have that, that is now a different sign for what's going on. Now that is going to point way more towards a cardiac tamponade. A cardiac tamponade is there's so much volume in this pericardial sac that it's impeding the outward flow. It's decreasing the stroke volume, and I've tried to compensate with the heart rate, but I just can't do it anymore, and it severely decreases the overall blood flow. When it decreases the overall blood flow, that can lead to states of shock, and if I don't correct that quickly, it can lead to death. So when we get to that point that we see that the body's been trying to compensate, can no longer do that, they're going to get real shocky. They're going to get real shocky, and if we don't fix that right now, it can lead to death. So some of the things that you might see when the patient presents with cardiac tamponade, you would see hypotension, decreased blood pressure. You would see JVD, jugular venous distension. Your jugular veins are going to be popping out like the rock after a workout. You're going to see pulsus paradoxus. So as that patient takes a breath in, you'll see a decrease in the blood pressure, and as they exhale, you'll see that come back out. The tachycardia, tachypnea, you'll have narrowing of the pulse pressure. A pulse pressure is the difference between your systolic blood pressure. So your pulse pressure is the difference between the systolic blood pressure and your diastolic blood pressure. So when that starts to narrow, when your pulse pressure decreases, when it gets closer together, one of the things you want to look at is cardiac tamponade. And then some of the last signs that you might see is dyspnea. So when we dive deeper into the heart, when we go beyond the pericardial sac, we start to see these three different layers of structures that are called the heart wall, that we describe as the heart wall. We have the epicardium, the myocardium, and the endocardium. When we look at the epicardium, this is the visceral layer of the overall walls, and it's made up of squamous cell epithelium, and later in life the epicardium can be infiltrated with fat, so it starts to impact its function as we get older in life. When we look at the myocardium, it's the middle layer and it's the thickest part of the wall, and it makes up the bulk of the heart. It's designed to contract. It's got this unique construction and arrangement of muscle cells that allows it to contract, and it does so in a spiraling motion. So if you were to wring out a wet towel perhaps, it squeezes and it wrings out, or the blood that's in the ventricles. So when we talk about that spiral motion, it's made possible by this unique cardiac muscle cells that are formed in this network spiral. So it creates this spiral and this squeeze and wringing motion that takes place in these what we call circular bundles. And modified tissue fibers that are associated or that make this conduction possible are what we call the SA node or the sinoatrial node, the atrioventricular node or the AV node. We have the bundle of His and the Purkinje fibers. And we'll talk about those as we continue to get into the electrophysiology and what those are. But we need to understand that those fibers that are used for conduction are the SA node, the AV node, bundle of His, and Purkinje fibers. When we look at the endocardium, this is the innermost, innermost, I guess that doesn't really rhyme, but the innermost layer when it comes to the heart wall. It has a thin layer of connective tissue that are white sheets of squamous epithelium, and we see that these white layers of squamous epithelium are found within the chambers of the wall of the atria and the ventricle themselves. These are the same epithelial cells that we have in our small blood vessels, as well as the great vessels. We have the same epithelial cells that are in those that we see in the endocardium. As we look at the atria are the upper portion. These are the upper portion of the heart. So we have atria. The way that I remember that is that A comes before V, and blood flow will go through the atria before it goes into the ventricles. But when we look at the atria, these are tiny thin-walled heart chambers. They have very little pumping when it comes to the overall circulation of blood flow. What it does is it simply has to get blood from its chamber into the adjacent chamber, which is down below. So gravity helps us out a whole lot with that, but they have just a little bit of a pump when it comes to moving blood flow into the ventricles. They're separated by the interaortal septa. Again, that's that little separation between the right and left atrium. But if you go back and you remember when we talked about fetal circulation, we had that foraminal valley that helped get blood from the right atrium over to the left atrium so that we could bypass blood going to the lungs. We have that in fetal circulation. In adult circulation or post-uterine life, that foraminal valley, it actually closes. That foraminal valley, that opening that's here, it closes and creates this little bit of a depression right here. That depression in the right atrium is what we call the fossa ovalis cordis. Now, it doesn't really have, or we don't know exactly what its function is, but we do know that it's formed from the foraminal valley. So again, that's the fossa ovalis cordis. And like I said, we don't know what the function is, but we do know that when there is dysrhythmias or arrhythmias that it is a site for blood to pool. So if we have a site for blood to pool, blood, if it's not being circulated, it will congeal, it will come together. When that blood comes together, it forms a clot. That thrombus is a clot. Essentially, that thrombus is a clot that can form from that foraminal fossa ovalis when we have patients that have a dysrhythmia. So when we look at the ventricles are the majority of the mass of the heart. So they take up the lion's share when it comes to how much mass they take up. And they're responsible for the bulk of pumping. So they get blood from the right ventricle into the lungs. And then from the left ventricle, that left ventricle has to then send blood all over the body. So when we look at the left ventricle versus the right ventricle, the left ventricle has a whole lot more work to do than the right ventricle does. But because they are separated, or they're joined essentially by the interventricular septum, the work that the left ventricle can do actually pulls on this intraventricular septum or the interventricular septum, and by the left ventricle working, it actually helps the right ventricle pump. So you get what's called left ventricular aid. Some seem to think that that left ventricular aid actually speaks to why right ventricular heart failure is less impactful than left ventricular heart failure. So when we have patients that have right heart failure, and through the work that the left heart does, it aids or it supports that right ventricle. So when that right ventricle stops working as effectively or efficiently as it should, then it gets the support that it needs from the left ventricle. Now when we look at the heart valves, there are 4 different valves. We have the tricuspid valve, that's between the right atrium and the right ventricle. We have the pulmonic valve, that's between the right ventricle and the pulmonary artery. We have the mitral valve, or the bicuspid valve, that's between the left atrium and the left ventricle. And then we have the aortic valve, which is between the left ventricle and the aorta, the heart. Now, when we look at the AV valves are the ones that are between the atria and the ventricle. So our tricuspid and our bicuspid. When we look specifically at the tricuspid valve, it actually has 3 valves. It has 3 flaps. And the way I like to look at this is like the Mercedes-Benz sign. So it looks like the Mercedes-Benz. And when those valves open, they allow blood in. When we look at the mitral valve, it only has 2 flaps. And when those open, it will allow blood into the left heart. So tricuspid is for the right heart, mitral valve or the bicuspid is for the left heart. Now, the structure that connects the heart wall to the valves themselves are what's called chordae tendineae. And the chordae tendineae are what the valves are anchored to between the valve and the cardiac walls. And we can have 2 different types of situations or errors or complications with these valves. We can get regurgitation or regurg, which is a backflow of the blood from a leaky valve. So you get a leaky valve that leads to backflow of blood. The other thing is we can have stenosis, and stenosis is the narrowing or the constricting of a valve that leads to blood backing up, which increases pressures backing up, which leads an impact to the cardiac performance. So when I look at these 2 conditions, regurgitation is that kind of gatekeeper that doesn't keep anything. It allows information to be passed through, or it allows extra blood to be passed through when it's not supposed to. When I look at stenosis, this is the ultimate gatekeeper. They don't open up for anything. So they are a challenge to open up, and no blood flow can come through. When we look at mitral valve stenosis, it can lead to pulmonary edema. Now, when we look at the semilunar valves are the interior valves that I kind of look at. They're the pulmonic and the aortic valves. And what's significant about them is they are designed to prevent backflow of blood into the ventricles during diastole. So we talked about a systolic blood pressure and a diastolic blood pressure. When we look at systolic, this is during contraction. When we look at diastolic, this is when the ventricle is at rest. So when the ventricle is not actively squeezing, when it's at rest, the semilunar valves are designed to not let blood come back into those ventricles. So they're designed to prevent the backflow of blood into the ventricles during diastole. During rest or during diastole, the AV valves open up and allow blood flow from the atria into the ventricles. During contraction, that blood that's filled up the ventricles go out either the pulmonic valve or the aortic valve into the pulmonary artery or the aorta to their respective places, and the semilunar valves help prevent blood flow from getting into the ventricles during that rest. So when we look at the semilunar valves, they can actually have regurgitation or stenosis as well. So parts of these conditions don't only impact the AV valves, they can hit the semilunar valves as well.